Today we're going to talk about external pacemaking for Putnam County EMT paramedics. Only paramedics for Putnam County EMS are allowed to do external pacing. We do it in two situations mainly. Patients that are in a full arrest with a systole confirmed in both leads, and they're not responding to any type of medication therapy, such as after you pushed your epi or atropine. And patients that are symptomatic bradycardia that are conscious and are still unresponding to atropine. Any other patients are under the discretion with online medical control physician. Also, external pacing can only be used on a pediatric patient with online medical controls direction. For your patient, if they have any nitroglycerin patches around their chest, you need to remove them. Make sure they don't come in contact with our defibrillation pads. Also, with pacing, anybody that's soaking wet, they need to be dried off. Be careful if you're trying to do it in a dive scenario or drowning scenario. You want to make sure that they're dry. We use our regular patches we use for all our regular patients for doing defibrillation. For your patients that are conscious and exhibiting signs of bradycardia, you want to do some pre-medication because pacing the conscious person is going to be very painful for them. So you're going to want to pre-sedate with either Versed or Valium, 3 to 5 milligrams, IV push, so make sure you get a IV established first. You can even administer your atropine prior to pacing. So once you get your IV established and you want to put your patches on, you can still push your atropine to see if they're responding to that. You don't necessarily have to go right to pacing if they respond to the atropine, but you have your patches on them so you're ready to go if you need to. Also, if your patient is stable at first with their bradycardia, make sure you're keeping an eye on them. They could go downhill real quickly, especially patients in a 2nd degree or 3rd degree heart block. You want to get your patches and get them ready to go for that patient. And make sure you definitely have a good patent IV running. Even a second line wouldn't hurt. Your atropine dosing is going to be 0.5 milligrams IV push for your conscious bradycardic patient. For a systole, it will be a 1 milligram IV push. So once you get your patches on, we're going to cover the first scenario here. We're going to cover is a conscious patient. You're going to pre-medicate them with Versed or Valium, 3 to 5 milligrams IV. Once you get them hooked up to your defib pads, and if you also want to do the 4-wire, that's not going to be a problem either. You can go ahead and do that. I'm just going to take this off the advisory for right now. So right now you can see that they are in bradycardia. We want to check with the patient to make sure they're showing signs and symptoms of bradycardia, which means difficulty breathing, cold, clammy skin, that general weakness and tired feeling. So we want to go ahead and once we have them pre-medicated, explain to the patient what we're doing, because this is going to hurt. There's just no way around it. They're going to feel a jolt of electricity, so they're not going to like it, but make sure they know what's going on. I'm going to turn the pacer on for the conscious patient. We're going to set it for 80 pacing beats per minute. And initially our current will be 20 milliamps. And we want to wait and make sure we have good capture. We want to see our pacer spikes are in tune with our QRS complexes. And you want to make sure that it is showing a good capture. If not, after about 10 seconds, you want to increase the current. And we're doing 20 milliamp increases every time. So we'll increase it to 40. We want to make sure we have good capture of that. Until we see the patients perfusing, they look better, they're starting to hopefully feel better. May or may not, because they are getting electrocuted. If that doesn't work, we're going to keep increasing by 20 milliamps every time. Oops. Once again, you want to make sure your pacer spikes are in tune with your QRS complex. We're going to leave the pacing beats a minute at 80. And keep a good eye on your patient, make sure that they don't become unconscious make sure that you have them on oxygen, monitor the entire time, and you may have to re-medicate them as needed for pain management. For the unconscious patient that is in a cardiac arrest after you've given your epi and your atropine, we're going to go ahead and try to pace this person. This person will be unconscious, so there's no pre-medication necessary. Hook up your patches as normal. Oops. Turn that off for a second. All right, you see they're in asystole rhythm. And turn the pacer on. We only use one setting for this. It's at 100 pacing per minute, and the milliamps is 200. We do not deviate from these settings. Within 20 to 30 seconds, hopefully, you can detect a carotid or even a radial pulse on this patient. The monitor right now, for demonstration purposes, is showing a good pacer spike before every QRS complex, but we also want to make sure that we are picking up a pulse on the patient. If we can detect a pulse, that's good. If not, after 20-30 seconds, you're going to want to turn the pacer off and go ahead and start manual CPR, or excuse me, resume manual CPR. But we want to keep an eye on our patient, make sure we maintain our capture during transport, and transport to the nearest facility as fast as possible. Once again, remember, taking off the nitroglycerin patches, they don't respond well to the electrical conduct here. Any other patients, once again, if they're any pediatric patients or anybody else, we want to get online medical controls consent before we go ahead and redo this. Reiterate, the patients that are in full arrest after we confirm at 2 leads that they don't respond to medication therapy, and then we want to go ahead and do external pacing. And for patients that are symptomatic bradycardia, after they don't respond to atropine, that's when we'll do external pacing. Thank you very much for your time.